Welcome to the deep dive. Today we are exploring, well, a really vital and deeply complex area of pediatric care, alterations in genetics.
It really is.
If you are preparing to work with children, the sheer weight of this topic, understanding the blueprint of life when it goes awry, it's immense.
Mm.
Our source material sets the tone perfectly, actually, reminding us that nursing means caring for the helpless and brave child victim of heredity. That's kind of the foundation for today.
It's such an emotionally charged field, isn't it?
Yeah.
And our mission for you, the listener, is really to synthesize the clinical necessity of all this.
Okay.
By the end of this deep dive, you should have a clear, actionable understanding of the key inheritance patterns, the nursing process that's tailored for these unique families, and the specific clinical realities of common disorders, particularly Down syndrome.
And this is all strictly drawn from the chapter content, right?
Absolutely, straight from the text.
Okay, let's start with the groundwork then. We often use terms maybe a bit loosely, but there's a critical difference here in pediatrics. When we talk about genetics, what are we really saying?
Right. Genetics is basically the study of heredity. But a genetic disorder, that's the key. It's a result of an actual abnormality in the individual's genome. It's a change in the blueprint itself.
Gotcha. So different from a familial disorder.
Exactly. And it's vital for assessment to distinguish that clearly. A familial disorder might look genetic because it runs in families, but the cause often involves, environmental factors mixing with some genetic predisposition.
Like heart disease, maybe?
Perfect example. Heart disease can be familial, but something like cystic fibrosis, that's a genetic disorder. And the text points out that while these problems can show up any time, the really severe ones tend to manifest earliest, often in childhood.
That makes sense. Okay, so moving into the sort of new landscape of genetics.
Yeah, the game has really changed.
The knowledge we have now is just dramatically different, isn't it? Largely thanks to the Human Genome Project, the HGP.
Oh, absolutely. Completed back in 2003. And it wasn't just about mapping, 3 billion base pairs or finding 20,500 genes, which is amazing in itself.
Right.
But arguably the most challenging part was ELSI.
ELSI. Ethical, legal, and social implications.
Exactly. And those implications are what directly shape, well, the future of nursing practice and policy.
How so?
Well, we now have these incredible tools, right? Genetic testing for carrier screening, prenatal diagnosis, even pre-symptomatic testing, figuring out if someone will get a disease years before symptoms even start.
Wow. That's powerful knowledge.
Powerful, but also, incredibly volatile.
And this is where it gets, frankly, a bit scary. We're talking fundamental rights, privacy, confidentiality, the risk of discrimination.
Precisely. Imagine a healthy young adult being denied insurance or maybe a job because a test predicts a disease risk way down the line.
Yeah, that's a huge ethical minefield.
It is. And the source material really highlights that nurses aren't just caretakers here. We're advocates. We have to be ready to help develop policies that protect patient autonomy, prevent discrimination.
So maintaining confidentiality is paramount.
Absolutely. And presenting all testing options in a completely non-directive way. That means we give the facts, we provide support, but the family, they make the final choice. No judgment, no steering.
Okay. That's a heavy responsibility. So to counsel effectively, we really need to understand the mechanics, right? The probabilities.
Exactly. The blueprint itself, we need to grasp the basic building blocks. You've got the genotype, that's the internal genetic code, which then dictates the phenotype, the outward characteristics you can see.
And the basic unit is the gene sitting on the chromosome.
Right. And remember, we get two versions of almost every gene. Those are called alleles. One from mom, one from dad.
Alleles, okay. And if they're the same?
Then the person is homozygous for that gene. If the alleles are different, they're heterozygous.
Got it. Homozygous same, heterozygous different.
And when we look at the most common single gene disorders, the Mendelian patterns, it really boils down to dominance and location, whether it's on an autosome or a sex chromosome.
Okay, let's break those down. First up, autosomal dominant. This is the 50-50 one.
Yeah, that's a good way to think about it. The key counseling point here is you only need one copy of the abnormal gene to actually have the disorder.
Only one.
Right. So if one parent is affected, there's a straight 50% chance the child will inherit that gene and also have the disorder.
And the critical distinction.
Male-to-male transmission can happen. That helps tell it apart from X-linked patterns later. Think of conditions like neurofibromatosis or Huntington disease.
Okay. Now let's switch gears to autosomal recessive. Here, the carrier status is central, right?
Absolutely central. For these conditions, you need two copies of the abnormal gene to be affected. Usually, both parents are clinically normal carriers. They each have one copy but don't show the disease.
So the risk calculation changes.
It does. If both parents are carriers, the risk of their child being affected drops to 25%. But, and this is important for counseling, 50% of their children will likely be carriers themselves.
So you have to think long-term about their future families, too.
Exactly. You're counseling not just about the affected child, but maybe about healthy siblings who might be carriers. This is the pattern for cystic fibrosis, sickle cell disease.
Understood. And finally, the X-linked recessive patterns. This is where gender comes into play.
Yes. Since males only have one X chromosome, they're much more likely to show the disease if they inherit that altered gene on the X. Females often have a normal copy on their other X chromosome, which usually protects them.
So more males affected?
Generally, yes. And for a woman who is a carrier, there's a 25% chance with each pregnancy of having an affected son. But crucially, male-to-male transmission never happens with X-linked inheritance.
Because fathers pass their Y chromosome to sons?
Exactly. Think of hemophilia, Duchenne muscular dystrophy, classic X-linked recessive.
Okay, that covers the main single gene patterns. But things get more complex, right? Multifactorial inheritance. That sounds messy.
It is a bit messier. It means multiple genes are involved, plus environmental factors. Think of common things like cleft lip and palate or pyloric stenosis. The recurrence risk is usually lower and harder to predict than with single gene disorders.
And sometimes there's a sex bias, like pyloric stenosis being more common in boys.
Right. Then you get into the really non-traditional patterns, like mitochondrial inheritance. Why is that one so specific?
Because mitochondria, the cell's powerhouses, they have their own DNA. And it's passed down almost exclusively from the mother to all her offspring, sons and daughters.
Makes sense why it often affects high-energy tissues then, like nerves and muscles.
Exactly. And then there's genomic imprinting. This one feels really counterintuitive.
It is pretty strange. Basically, the expression of a gene depends entirely on which parent you inherited it from. You have both alleles, but only one of either the maternal or the paternal one is switched on.
So the same gene region can cause different syndromes depending on the parent.
That's right. That's how you get conditions like Prader-Willi and Angelman syndromes, caused by issues in the exact same spot on chromosome 15, but differing based on parental origin.
Fascinating. Okay, so knowing the patterns is one thing, but bridging that science to the family, that brings us to genetic counseling.
Yes, the communication bridge. It's an educational process, providing information about heredity, risks, options, management, all that.
And the nurse's role here.
We're crucial for the follow-up, the emotional support, making referrals. We need to know who actually benefits most from a formal genetic counseling referral.
The chapter lists some indicators, right?
Yeah, things like maternal age over 35 or paternal age over 50. Also, if they've had a previous child with a genetic issue or experienced multiple pregnancy losses. Consanguinity-related parents is another flag.
And the first step in counseling is often information gathering, like drawing up a pedigree.
Exactly. The pedigree is essentially a family health tree. Ideally, you go back 3 generations to see patterns.
And confidentiality is key there.
Paramount. Especially if sensitive information comes up, like adoption history or maybe IVF use. You have to build trust.
Okay, let's talk about chromosomal abnormalities themselves. These aren't always simple inheritance, right? Sometimes it's errors in cell division.
Correct. The most common error is non-disjunction. That's when chromosomes fail to separate properly during meiosis, leading to cells with either an extra chromosome, a trisomy, or one missing a monosomy.
Like trisomy 21, Down syndrome.
The classic example. And the main tool to visualize this is the karyotype.
The picture of the chromosomes.
Right, a pictorial analysis. One important concept here is mosaicism. Have you encountered that?
Where the abnormality isn't in all the cells.
Exactly. Some cells have the normal number of chromosomes, some have the abnormality.
Yeah.
This usually leads to milder symptoms, which is important for prognosis and counseling.
Good point. All right, let's quickly cover some key diagnostic tests, the invasive ones first. Amniocentesis and CVS.
Right, amnio and chorionic villus sampling, both used for definitive chromosomal and genetic testing. The key nursing difference is timing. CVS can be done earlier, first trimester usually, but amnio, done later, can also detect neural tube defects, which CVS can't. That's a crucial difference.
Okay. Then we have the non-invasive screening tests, like the triple or quad screen fetal nuchal translucency.
Yes, FNT. And the most critical nursing takeaway here is that these are screening tests. They tell you about risk, not diagnosis.
So an abnormal result doesn't mean the baby definitely has a problem.
Absolutely not, and you have to communicate that clearly. An abnormal screen means more testing, often invasive testing, is needed for confirmation. That's a super stressful time for parents, and the nurse needs to guide them through it.
Understood. And finally, the newborn screening, usually done 24-48 hours after birth. Why is that timing so critical?
Because it catches potentially life-threatening genetic illnesses, especially those inborn errors of metabolism, before symptoms even start. Early detection means immediate intervention, often just dietary changes, that can prevent irreversible brain damage or even death. It's truly life-saving.
Wow. Okay, so let's shift to the nursing process in practice. When you have a child with a known or suspected genetic issue, what are the assessment priorities in the health history?
You really need to nail down those risk factors we mentioned: parental age, any teratogen exposure, family history, and look for specific neonatal signs like really low muscle tone, hypotonia, or maybe an abnormal newborn screen result.
And the physical exam, it's about more than just the obvious
Right?
things.
Oh, definitely. You become a bit of a detective looking for visual clues. The text distinguishes between a major anomaly, something needing medical or surgical help, like a cleft palate,
Right.
and minor anomalies. These are things like low-set ears, maybe certain facial features, single palmar crease. By themselves, they don't cause health problems.
There's a but, isn't there?
There is. Here's the critical alert. Finding 3 or more minor anomalies significantly bumps up the risk, like up to 26% chance that the child also has a major underlying defect or an intellectual disability.
So those little things add up to a big warning sign.
They really do. And don't forget your other senses. The source stresses detecting specific odors, especially for inborn errors of metabolism.
Odors? Like what?
Well, phenylketonuria, PKU, can give off this sort of mousy or musty body odor. Maple syrup urine disease smell, well, like burnt sugar.
Yeah.
If you smell that as a nurse, it's a huge red flag needing immediate action.
Incredible. Okay, moving to interventions, especially psychosocial support. These families are under immense stress. What about the diagnosis-deficient knowledge? How do we teach such complex stuff?
You break it way down. Short, repeated teaching sessions. Use simple language, tailored it to their level of understanding, not yours.
Yeah.
And use multiple methods: talk, show pictures, give written info, not just a handout.
Makes sense. What about decisional conflict? Parents facing tough choices, maybe about testing or treatment. How do we stay non-directive when they might be asking us what they should do?
Oh, that's one of the hardest parts of nursing ethics, isn't it? They're stressed, looking for guidance. But our role is to help them explore their own feelings and values. Encourage them to talk it out. Maybe list the pros and cons of each option as they see them. We provide information, clarify things, but we absolutely maintain a non-directive stance. The final choice has to be theirs. We support whatever they decide.
Respecting their autonomy, crucial. And finally, promoting development for kids who might have delays. What's the key message for families?
The key message is that progress, even if it's slow, is continuous. We use age-appropriate play, therapeutic play, and we celebrate every single milestone, no matter how small it seems.
And emphasize that they follow the same sequence.
Exactly. They'll hit the same milestones as typical kids, sitting, walking, talking, just usually on a delayed timetable. That predictability can be comforting.
Okay, great. Let's focus now on some specific disorders mentioned in the text. Clinical care focus. Starting with the most common chromosomal one, trisomy 21, Down syndrome, patho first.
Right. 95% of the time, it's due to non-disjunction, that extra copy of chromosome 21. And we know the risk goes up with maternal age, especially over 35.
And the clinical features are pretty characteristic, right?
They are. The flattened back of the head, occiput, the depressed nasal bridge, those upward slanting eyes, oblique palpebral fissures, often poor muscle tone, hypotonia, and sometimes that single deep crease across the palm.
But management isn't just about the features, it's about the associated risks.
That's the core of management. The risks for co-occurring conditions are really significant.
How significant?
Well, about 40–50% have congenital heart defects. Over 75% deal with hearing loss or chronic ear infections.
Sure.
More than half have obstructive sleep apnea. These need active screening and management.
And there was something about the neck.
Yes. Crucially important. Atlantoaxial instability.
Right.
Increased looseness between the first 2 cervical vertebrae.
Which means
It means risk of spinal cord injury. So these kids need cervical spine x-rays, usually between ages 3 and 5. And nurses must be careful during positioning, avoid hyperextending or overflexing the neck. Huge safety issue.
definitely. And developmentally, you mentioned the sequence is the same but slower.
Right. The text gives examples like Walking average is around 24 months for kids with Down syndrome, compared to maybe 12 months typically. Same steps, different timeline.
Got it. What about the other trisomies, 18 and 13?
Much, much more severe, unfortunately. Most infants don't survive the first year. Trisomy 18 often has a prominent occiput, clenched hands. Trisomy 13, you might see microcephaly, cleft lipolate, maybe extra fingers or toes, very serious conditions.
Okay. And then the sex chromosome disorders, Turner syndrome in females.
That's XO missing one X chromosome. Hallmarks are short stature, often a webbed neck, wide-spaced nipples, and usually infertility.
And Klinefelter syndrome in males.
That's XXY. These individuals are often taller than average, may develop breasts during puberty, gynecomastia, and have underdeveloped tests, usually leading to infertility. Diagnosis is often delayed until adolescence because the signs aren't always obvious early on.
Okay. And neurofibromatosis, autosomal dominant. Right. What's the key sign a nurse looks for?
The absolute hallmark is the presence of 6 or more café-au-lait spots, those flat, light brown skin patches. In a child, they need to be bigger than 5 millimeters across. Also look for freckling in the armpits or groin, and possibly neurofibromas later on.
6 or more spots. Got it. Lastly, let's circle back to those inborn errors of metabolism, IEMs. You said newborn screening catches them.
Yes, thankfully.
Yep.
Most are autosomal recessive, and if they're not treated right away, often in the newborn period they can be devastating or lethal. Key is often diet.
Like PKU.
Phenylketonuria, exactly. Managed with a lifelong, very strict, low phenylalanine diet. That means restricting high-protein foods like meat, dairy, nuts. It requires constant vigilance from the family.
And galactosemia.
That requires complete elimination of all galactose and lactose, basically.
Yeah.
All dairy products from the diet. For life. Again, huge implications for family education and support, which is where nursing is vital.
Absolutely. Wow, that covers a lot of ground.
It's a huge topic. So, to sort of summarize the essentials for you, the nursing student, you absolutely must grasp the differences in those inheritance patterns and what they mean for risk.
Okay.
Your assessment has to be meticulous history, physical exam, looking for those subtle clues like minor anomalies or even unusual odors.
Right, the detective work.
Exactly. And recognize that caring for these kids and families is complex. It's individualized, it takes a whole team, and it demands relentless support and ongoing education for that family unit.
That support role feels like where the science really meets the art of nursing. Consider that profound shift. The moment a family gets a genetic diagnosis, their whole world changes instantly and forever. How do you, as the nurse, move beyond just the clinical plan? How do you build that deep, trusting relationship that validates all their feelings, the fear, the grief, the uncertainty, and really supports their journey, no matter how complex the medical side is?
That relationship. That's really the measure of truly successful pediatric nursing in this area, isn't it? It's the foundation for everything else.
It really is.
Well, thank you for joining us for this crucial deep dive into pediatric genetics.
We really hope this gave you a solid roadmap through the chapter. Until next time.